Okay, Bismillah. Okay, Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Dear colleagues, this is a short live session about bleeding that's related to cardiac drugs. As you know, in cardiology, we use many drugs that may cause bleeding. These include antiplatelet drugs like aspirin, P2Y12 inhibitors like Clopidogrel, Prasugrel, and ticagrelor. We use also glycoprotein 2B3A inhibitors. We can use also anticoagulants like heparin, unfractionated heparin, low molecular weight heparin, Warfarin, and dabigatran, Rivaroxaban, and Rivaroxaban. Also thrombolytic drugs like streptokinase or tissue plasminogen activators. All of these medications can cause significant bleeding, and as you know, bleeding may be associated with significant mortality and significant major cardiovascular events, including strokes, including myocardial infarctions, including heart failure, and non-fatal cardiac arrests. Bleeding may just affect your medication, so you may find yourself obligated to stop your medications, your essential medications like anticoagulants or antiplatelets, in addition to its direct effect may lead to significant anemia and shock and mortality. So bleeding overall is associated with significant mortality and bad outcome in cardiac patients. So in this short session, we are going to focus on practical issues and try to minimize bleeding. So we try to prevent bleeding or to minimize it, and we try to treat bleeding once it happens effectively by the use of specific antidotes or by the use of some supportive measures. Okay, let's go as I said, we are going to go very practical and to the point, inshallah. So what do we want? We want to prevent or minimize bleeding urgently or electively. Urgently means if you have a patient and he is already receiving some antiplatelets or anticoagulants, and now he is in need for urgent surgery or urgent intervention that may cause significant bleeding. So in this at this time we need to prevent this from happening, or at least to minimize this. Electively, if a patient is planned for some elective procedures or elective surgery, so we have to take some action to prevent this bleeding. And also we want to treat this bleeding, as I said, by using specific antidotes, blood products. So in order to prevent bleeding, so we need to stop the antiplatelet or the anticoagulant for sufficient time before the procedure. So just in short, in case of aspirin, we may need to stop aspirin about 5 to 7 days before surgery. However, in most of surgeries, still we can continue aspirin. So no need if the patient, for example, on a dual antiplatelet therapy, aspirin and Clopidogrel, or aspirin and ticagrelor, and the patient is on dual antiplatelet therapy, we just may need just to stop Clopidogrel or ticagrelor, and we can continue aspirin in almost all surgeries. There is an exception which is neurosurgery. So if a surgery is in a closed space, so like spinal surgery or neurosurgery, so it's better to stop also aspirin. So we stop aspirin and clopidogrel if the patient is on dual antiplatelet therapy. Of course, this is not an easy decision, especially if the patient is on the dual antiplatelet therapy for a drug-eluting stent, and he needs these medications. So the situation is not always easy. I'll go through this later. For clopidogrel and ticagrelor, we need 5 days before elective procedures or elective surgery. If clopidogrel is used alone, so it may be used as an alternative to aspirin, so we deal with clopidogrel as an aspirin. So in most of the surgeries, we can continue clopidogrel single therapy for patients undergoing elective procedures. Prasugrel, at least we need 7 days to stop before surgeries. So clopidogrel and ticagrelor, 5 days. Prasugrel, 7 days. Okay. For the anticoagulants, in short and a very practical approach, for the unfractionated heparin, we go for 6 hours. For a low molecular weight heparin like enoxaparin, we go 12 hours at least before surgery. And for Rivaroxaban or the Relto, we need to stop at least 24 hours before surgery. We may need to increase these durations if the patient has some moderate to severe renal impairment, so we may go for 48 hours. Dabigatran, we need 2 to 3 days before surgery. So usually we need 3 days if the patient has some renal impairment. Warfarin, we need 3 to 5 days before surgery, unless the INR is already low. If the INR is already low, below 1.5, so we may go for surgery and no need to wait for 3 to 5 days. So this is kind of practical, rapid approach. Sometimes the patient's coming with bleeding due to these medications, or the patient's coming and he's in need for an urgent surgery, maybe a neurosurgery or urgent abdominal surgery, and there's no time to stop these medications electively. So at this time you may need to intervene and to manage the situations. Okay. So, just we start with the heparin and enoxaparin. So, as I said, we need to stop unfractionated heparin at least 3 to 6 hours before elective surgery, or 12 hours for enoxaparin. If the patient is taking heparin and enoxaparin and presented with significant bleeding, so how to deal with these situations? Of course, like every bleeding, so you are going to manage to resuscitate the patient, starting IV fluids. You may need to request some blood products, packed RPCs, or fresh blood according to the situations. However, you need to give a specific antidote. The specific antidote for heparin is protamine sulphate. First, we have to note about protamine sulphate that we don't give unless there is bleeding. So we don't give protamine sulphate just because the APTT is just very prolonged or something like that. So only if we have bleeding related to heparin or enoxaparin, we can reverse with protamine sulphate. Otherwise, we don't give. So specifically, protamine sulphate is antidote for heparin, unfractionated heparin, but it's also working with low molecular weight heparin like enoxaparin although it's less effective than it does with heparin or unfractionated heparin. Usually the dose is variable, and according to the timing and according also to the previous dosage of heparin. In short, usually we give protamine sulphate by IV infusion, so never to give protamine sulphate a very rapid IV, because in these cases it may lead to severe hypotension, or even sometimes can lead to severe reactions. So we give it infusion or slow IV over 10 minutes, so we don't give it rapidly. So at least 10 minutes infusion of the 50 milligram protamine sulphate. For heparin, usually we give 1 milligram for each 100 units. However, this is dependent on the timing. So for unfractionated heparin, usually if the patient has taken the last dose within the last 30 minutes, so we give the full dose. So we give 1 milligram for each 100 units. So if the patient, for example, took 5,000 units, so we give 50 milligrams. And if the last dose was from 30 minutes to 2 hours, we give half the dose. So we give only 25 milligram. So if this was more than 2 hours, we give only just 1/4 of the dose. So we may give only about 12 milligrams. So 30 minutes, up to 30 minutes, we give the full dose, 1 milligram for each 100 unit. And from 30 minutes to 2 hours, we give half the dose, so 25 milligram for 5,000 unit. And if more than 2 hours, we give only 12.5 units, so 1/4 of the dose of the last dose of heparin. Regarding low molecular weight heparin, like enoxaparin, usually we give 1 milligram of protamine sulphate for each 1 milligram enoxaparin. So the patient is taking 60 milligram, we give 60 milligram. 80 milligram, we give 80 milligram. If the patient already has taken the drug within the last 8 hours. If it's more than 8 hours, so we may give a lower dose. So we may have this dose. Can we repeat the dose? Yes, we can repeat the dose if we did a PTT after 3 to 4 hours, or if still there is repeated bleeding, so we can repeat the dose for protamine sulphate. So as I said, we have to give slow IV at least over 10 minutes, and to take care of the reaction and severe hypotension. Okay, so let's move to the next one. This is okay. Warfarin. Of course, warfarin is a very commonly used drug. So warfarin is used for cases of DVT, pulmonary embolism, atrial fibrillations, and cases of left ventricular thrombus. So it can be given in different indications, and because it's quite cheap drug, so it's commonly prescribed drug. Of course, we know that warfarin has many disadvantages, including the drug-drug interactions, interaction with food, the need for continuous monitoring with PT and INR, and also the problem, some side effects and complications associated with warfarin, the risk of bleeding. even so, still this drug is a very commonly prescribed drug, and it may be associated with bleeding, or sometimes you may need to rapidly reverse the effect of warfarin. For example, if a patient is going to undergo an urgent surgery, and there is a significant bleeding risk, and you did the INR and you found it's a bit high, so you need to reverse this effect and go with the INR below 1.5 to make the situation more safe. So if the patient presented with bleeding due to warfarin, what to do? Sometimes the patient presents with just prolonged INR, and sometimes present with bleeding, either minor bleeding or a major bleeding. As a general rule, if there is only prolonged INR, okay, so only prolonged INR, usually no need to give antidote unless the INR is above 8. So if the INR is above 8 and no bleeding, we may go just for giving oral vitamin K, 1 to 5 milligram oral vitamin K, and we hold warfarin, of course, and we repeat the INR after 24 to 48 hours, and if still the INR is high, we give another dose. So INR is high, above 8, so we may give oral vitamin K. If it's below 8 and no bleeding, no need to do anything, just hold the drug and repeat the INR frequently until the INR go below 5, and at this situation you may resume the drug with the lower dose. Okay. In case of bleeding, we may have a minor bleeding and we may have a major bleeding. So our first step is just an oral vitamin K. If we have a minor bleeding, there is a debate or there is controversy. Do we need to give oral vitamin K or injectable vitamin K? There is a debate about it from the American guidelines or NICE guidelines. Anyhow, you need to give vitamin K in case of a minor bleed. If you are going to give injection for vitamin K, injections, subcutaneous or intramuscular, or of course you have to avoid intramuscular in a patient taking already taking anticoagulant, because there is risk of hematoma. So if we are going to give with IV, we don't give IV vitamin K, I mean rapid IV. So if you are going to give vitamin K, always ensure that the drug is given very slowly. So you may give up to 10 milligram and don't give above 10 milligram. Above 10 milligram is quite high dose, and may be associated with great difficulty in reversing or in reinstituting warfarin again, if it's used for thromboembolism or it's used for atrial fibrillation. So no need to give above 10 milligram IV vitamin K. Always give vitamin K by IV infusion, so slowly IV. Don't give more than 1 milligram over less than 1 minute. So if you are going to give, for example, a 10 milligram, at least you need to give over 10 minutes, and it's better to give it much more slower, maybe over 30 minutes infusions. Okay, so dilute and give slowly, never to give IV bolus. IV bolus of vitamin K may be associated with severe reactions, and it may be associated with even sudden death. So never ever to give a rapid bolus of vitamin K. Always give by infusion, slowly, IV, or you may give even subcutaneous if there is no IV line. So when we give this if we have bleeding, either a minor bleeding or a major bleed. NICE guidelines recommend only giving just American guidelines just recommend give oral vitamin K when you have a mild bleeding. Okay, If you have a major bleed, so we need to be more radical. So we need to give either a prothrombin complex concentrate, and if it's not available, we go for fresh frozen plasma. We need maybe 4 to 5 units of fresh frozen plasma. So if we don't have a prothrombin concentrate, we get for fresh frozen plasma. In addition to vitamin K. Vitamin K, it takes few hours for the action, to the onset of action. It takes few hours and needs about 24 hours to have a full effect. So vitamin K is given as adjunctive to fresh frozen plasma or prothrombin concentrate in case of major bleeding. Okay, so the message from this slide: never ever to give IV vitamin K rapid IV. Always give slowly IV. If there is a difficulty to give IV infusions, you may give subcutaneous, or you may use oral vitamin K. Of course, unless there is a contraindication for oral intake, like upper GIT bleeding, something like that. So in a major bleed, fresh frozen plasma or prothrombin concentrate. And prothrombin concentrate, of course, is priority. So we give vitamin K. If also we need to rapidly reverse this vitamin, the warfarin, so we may go also vitamin K and fresh frozen plasma or prothrombin concentrate for in case of need for rapid reversal. Dabigatran, we know dabigatran is a direct antithrombin, a direct oral anti-thrombin. It is antidote for dabigatran is called idarucizumab. Idarucizumab is a monoclonal antibody. Okay. Idarucizumab is the monoclonal antibody used for reversal of the effect of dabigatran in case of significant bleeding. Of course, the problem with this is the cost. So the patient needs usually 2 vials. So each vial is 2.5 grams. So the patient usually needs 5 grams of infusion. So we finish the vial and we move to the next vial infusion. So the patient needs 2 vials, and this usually costs at least $4,000. Okay, so it's a bit costly antidote, but it may be needed in case of severe bleeding associated with dabigatran, or if you need to rapidly reverse the effect of dabigatran in case of an emergency surgery and the patient is already taking the drug. So that's about idarucizumab. Okay, in case of bleeding, and you can resume the dabigatran if needed after 24 hours. Regarding Rivaroxaban, so Rivaroxaban is a quite expensive drug, and its antidote, andexanet, is a quite very expensive antidote. So that's very expensive. So Rivaroxaban, it's a oral factor 10 inhibitor, and the drug, as we already mentioned, you need to stop this drug at least 24 hours before any elective surgery or elective procedures that may be associated with bleeding risk. In case of significant bleeding related to Rivaroxaban, you may need to give the antidote, which is a very expensive drug. There are 2 regimens to antagonize the effect of Rivaroxaban. Andexanet is just a recombinant factor, activated factor. So this is a recombinant activator factor 10. It's used for Rivaroxaban and apixaban. So it's not used for example, injectable IV factor, injectable factor 10 inhibitors like fondaparinux or like enoxaparin. It's only used for oral factor X inhibitors like Rivaroxaban or apixaban. The patient may need up to, from this there are two types of vials, 200 milligram vial or 100 milligram vials, and the total cost for antagonizing to use this antidote, it may reach up to $50,000. Okay, $50,000 to antagonize the effect of Rivaroxaban. So this is a very great and very great limitation for using this drug. But although it is a commonly used and the prescribed drug now, but you have to take care about this possibility. The very expensive antidote, up to $50,000 to antagonize the effect, because usually you need about 9 vials of 200 milligram or 18 vials of 100 milligram with the high dose regimen. So there is a low dose regimen and the high dose regimen. So maximum we need maybe we need $50,000, or in a low dose regimen we need about $25,000 or $27,000. Otherwise, you will go for just supportive treatment, blood products. The glycoprotein 2B3 inhibitors. Glycoprotein 2B3 inhibitors are only used in certain specific situations, and my colleagues, the cardiologists, already know. The patient may be used a very procedure during PCI with a high thrombus burden or high risk situation. So it's not used, of course, routinely for acute therapy of acute coronary syndrome. It's only used for patients already underwent a PCI or going to undergo a PCI, a primary PCI, for example. Or it may be continued for up to 24 hours after attempted PCI if there is a high thrombus burden. So glycoprotein 2B3 inhibitors are quite very strong drugs and can lead to significant bleeding. We have, these are the used glycoprotein 2B3 inhibitors. The apixaban, it's a monoclonal antibody, and you have eptifibatide or integralin and tirofiban, or it's used like agrastat. Apixaban is a monoclonal antibody, and eptifibatide and tirofiban are like a small molecule receptor antagonist. Integralin and the agrastat or eptifibatide and tirofiban have a quite shorter plasma half-life. So the half-life for these drugs is quite short, maybe just something like 2 hours. So usually within 4 to 6 hours, at least 50% of the platelet may resume the activity. This is regarding tirofiban and eptifibatide and integralin, and these are the commonly used drugs in many countries. They have a short half-life of about 2 hours. Okay, apixaban has a quite longer half-life. So although it has a quite short plasma half-life, but had a quite prolonged biological half-life, and sometimes its effect may last up to 48 hours, and it may even extend to more than that, maybe up to 1 week. So at least 48 hours, the effect of apixaban may continue. So, however, for tirofiban, it's only just 4 to 6 hours, and at least 50% of the platelets will resume their activity. So, in case of bleeding related to eptifibatide or tirofiban, just stopping the drug and just watching observations and use of local measures, if local measures can be done, that may be the whole thing that's needed for these two drugs, integralin or tirofiban. So because usually within 46 hours, usually we will assume at least 50% of the platelet activity. So maybe just waiting. For apixaban, because it's a quite prolonged biologic half-life and the effect may reach up to 48 hours. So in case of significant bleed, we may need to have a platelet transfusions. Platelet transfusion may be necessary for these cases. Okay, so when we need to stop these drugs, of course, if we have bleeding or if we check the platelet count, we have to check the platelet count at least 2 to 4 hours after initiation of the drug. If the platelet count goes down more than 50% from the baseline, or if the platelet count became less than 100,000, so in this situation we need to stop the drug. Okay, and we may just stopping the drug, maybe that the whole thing needed. So significant thrombocytopenia mandate stopping this drug. For apixaban, also we will stop the drug. In case of bleeding, just waiting, observations, local measures for eptifibrillide and tirofiban. Apixaban, we will need a platelet transfusion if we have significant bleeding. And of course, we need a number of platelet units according to the number of the platelets. So if the platelet is less than 50,000, the platelet less than 50,000 with bleeding, so we give platelets. Or if the platelet count is less than 20,000, we need to give platelets. So platelet transfusion if the platelet count is less than 20,000, or if less than 50, in addition to bleeding. Okay, so usually each unit of these platelets usually will add about 6 to 10,000 of platelets to the circulation. So we'll increase the platelet count by 6 to 10,000. Okay. Regarding antiplatelet therapies, aspirin, clopidogrel, prasugrel, and ticagrelor. As I said, most of the surgeries, aspirin, in a patient taking aspirin, for example, for stable coronary artery disease or after acute coronary syndrome. Of course, if there is a significant risk of bleeding and there is a low risk of thrombosis in the patients, of course, considering stopping of aspirin may be appropriate. So the data in these areas are quite gray. So it's a kind of gray zone because there are no large randomized trials, and most of the opinions is based on like an expert opinions in this area. So as a general rule, we can continue aspirin for elective surgery. Now this is a different situation. So now this is an emergency surgery and the patient is already on aspirin. So what to do? Usually no need to stop aspirin in most of surgeries, as I said. However, in some situations we may need to reverse this effect of aspirin. For example, if the patient is undergoing a neurosurgery, an urgent neurosurgery, or a spinal surgery. So in case of urgent neurosurgery or a spinal surgery, we may need to reverse the effect of aspirin. This may need mandate the use of platelets. So we may need to up to 5 to 6 units of platelets in an average adult to reverse the effect and to protect against bleeding, especially with a neurosurgery or a spinal surgery. So platelets, like You can see like Antidote in case of the need for rapid reversal. In case of Clopidogrel and Rivaroxaban, and there is a need for rapid reversal and emergency surgery, whatever, a neurosurgery or non-immunosurgery, and the patient is taking a dual antiplatelet therapy, and we need to reverse this effect. So we give also platelet transfusions. We don't look to the number of the platelet because we have a problem with the platelet function in these patients. So we give a platelet transfusions. In case of Clopidogrel or Rivaroxaban, we give a higher number of units, up to double the number used with aspirin. So we need to up to 10 units of platelets. For ticagrelor, the situation is a bit different because ticagrelor, the platelet transfusion is less effective than the other drugs like Clopidogrel or Rivaroxaban. If ticagrelor is already used in the last 24 hours, usually platelet transfusion is not effective. It may be effective if ticagrelor was used more than 24 hours. It can have a partial neutralizing effect in these cases. So ticagrelor within 24 hours, no rule for platelets. For more than 24 hours, we may give platelet transfusions. For all of these three drugs, aspirin, Clopidogrel, Rivaroxaban, and tranexamic acid still can be used and can reduce the effect of bleeding. Some investigational, some drugs that can be used for another indication, they don't have a strong recommendation or strong evidence to use, like desmopressin or recombinant factor 7. So the main reversal for the antiplatelets is platelets, and maybe also we use in addition to that tranexamic acids. If the situation with the dual antiplatelet therapy, so we use aspirin, Clopidogrel for patient, for example, already has undergone drug-eluting stent or a perimeter stent. In these patients, we may need to stop these medications by sufficient time. As I said, 5 days for Clopidogrel and ticagrelor, 7 days for Rivaroxaban. However, the situation needs to be individualized. That means, so you check the risk of thrombosis and the risk of bleeding in these patients, and according to the risk of bleeding, dependent on the patient comorbidity, the age, and the type of surgery, so high bleeding risk, and the risk of thrombosis according to the type of stent, according to the site of stent, number of stents, and so on. So you weigh the risk of bleeding against the risk of thrombosis. As a general rule, as I said, in case of a drug-eluting stent, don't commence elective surgery except after 6 months. And for a perimeter stent, at least 4 weeks before commencing elective surgery. However, if the surgery can't be postponed, we do this weighing of risk of thrombosis against the risk of bleeding. If you have a patient with, just in short, a patient with a high risk of thrombosis, so a drug-eluting stent in the left main artery, for example, and high bleeding risk, so a bloody surgery, and you expect excess bleeding in the surgery, or anticipate excess bleeding, what to do in these situations of high bleeding risk and high thrombotic risk? Just in short, we continue aspirin and Clopidogrel, and then we stop Clopidogrel and give and bridge with short-acting glycoprotein 2B3 inhibitors, for example. So you continue aspirin Okay, you stop clopidogrel and bridge with glycoprotein to be 3 inhibitors. Okay, if there is high thrombotic risk and low bleeding risk, there are many factors act in both ways, and a low bleeding risk. So you continue the dual antiplatelet therapy and you don't stop aspirin or clopidogrel or aspirin or clopidogrel. So you continue both drugs. If the reverse, so if there's a low thrombotic risk and the high bleeding risk, we continue aspirin and stop clopidogrel. Okay, stop clopidogrel, and we resume clopidogrel maybe once it can be reinstituted, maybe 2 to 3 days after surgery. Okay, so bridging in case of high thrombotic risk. Okay, in case of high thrombotic risk and high risk of bleeding, you stop clopidogrel, continue aspirin, and bridge. If there is high thrombotic risk and the low risk of bleeding, you continue both antiplatelets and don't stop any of them. If there is a low thrombotic risk and high bleeding risk, still you continue aspirin and stop clopidogrel and resume 2 to 3 days once appropriate after surgery. And by this slide we conclude this session. I just want to summarize in a very short way. So we need to minimize bleeding, try to stop bleeding if it happened with the use of antiplatelets or the anticoagulant, and also we want to prevent bleeding. So in case of elective surgery, just to memorize this, in aspirin you need to stop 5-7 days. No need to stop aspirin in most of surgeries, only maybe some neurosurgery or spinal surgery you need to stop aspirin. Clopidogrel, stop 5 days, and however you deal with clopidogrel if it's used as a single therapy instead of as an alternative to aspirin. So you may continue if there is a low bleeding risk. So it's okay if it's used as an alternative to aspirin. For Prasugrel, 7 days. For anticoagulant, 6 hours for heparin, 12 hours for enoxaparin, and 24 hours for Rivaroxaban. Dabigatran, 2 days, 3 days if there is some renal impairment. Warfarin, 3 to 5 days if there is a prolonged INR. However, if the INR is below 1.5, we can go directly to surgery and we need to postpone these days. For heparin and low molecular weight heparin, we can use Protamine sulphate, never to give IV pills. It's given infusion, 50 milligram at least over 10 minutes, and the dose is dependent on the duration of the last dose and the dose also. So according to for heparin, 30 minutes to 2 hours, below 30 minutes, more than 2 hours. And then 30 minutes, we give the full dose, 1 milligram for each 100 unit. 30 minutes to 2 hours, we give half the dose, and after 2 hours, we give only 1/4 of this dose. For warfarin, if the INR is prolonged and no bleeding, no need to give any drug, give oral or vitamin K. If the INR is above 8, you may give oral vitamin K and repeat the INR after 24 to 48 hours. If there is a minor bleeding, you may give oral or IV vitamin